So good morning, everyone, and good evening to our participants in Australia, New Zealand, and on that side of the world. Welcome to today's nephrology webinar series, our Fireside chat. It will be the 153rd session today. My name is Dr. Yuri Okech, and I'll be your moderator for this session. So today we'll be kicking off our nutritional webinar series. So this will be the first one, the first kickoff. And we'll be delving into a topic on dietary approaches to lower blood pressure. And our guest speaker for this morning or evening rather is Professor Karen Charlton, who is an advanced accredited practicing dietitian and a registered public health nutritionist. Professor Karen conducts food-based clinical trials to identify the role of nutrients, foods, and dietary patterns on health outcomes. She will present on her research conducted in South Africa that led to a mandatory salt reduction targets and the evaluation of that policy. She will also address other aspects of diet that affect blood pressure, which is a major risk factor for kidney disease, hypertension, and cardiovascular disease. Professor Karen has published over 260 publications with co-authors from 16 countries. She holds an Australian Research Council Future Fellowship to investigate strategies to create a more sustainable, equitable, and healthy food systems. So welcome, Professor Karen, and looking forward to an enlightening talk this morning. Thank you. Over to you.
Yeah, thank you very much for that introduction, and it's a great pleasure to be able to speak to you today from Australia. Good morning to all of you. It's good evening from me. It's evening on this side of the world, and it gives me great pleasure to be able to talk to you about a whole sort of 15 years, I guess, a bit longer, of research I've been doing around diet and blood pressure. So at the moment, I am based in Australia, and I thought it would be a good idea just to show you exactly where I am in the world. So for those of you that are not familiar with the geography of Australia, you might have heard of Sydney. We're based in Wollongong, which is about 80 kilometers south of Sydney. So we're on the southeast side of the continent of Australia. And this is what Wollongong looks like. It's a very beautiful coastal town. But I didn't always live in Wollongong. I have been in Australia for 17 years, but prior to that, I was at the University of Cape Town. I was at the Medical Research Council in Cape Town. And I did actually grow up in Botswana for most of my young years, and also Zambia, and went to school in South Africa. So I do consider myself still an African. Some of the work I'll show you today has been funded by Bloomberg Philanthropies Foundation, and also LINKS, which is a collaborative effort of WHO and other philanthropies as well. So that's a disclosure I have. Okay, this is a really busy slide, but I just wanted to point out to you why blood pressure is such a problem in most of sub-Saharan Africa. So this is data from a pooled analysis of 19 million participants. This was published in The Lancet a couple of years ago, and it's broken down according to different regions. So the top part of this graph is men, and you can see over, well, since 1975, there has been a reduction in the prevalence of people with high blood pressure. This is a global reduction in terms of age standardized prevalence. The graphs at the bottom here are for women, and again you see this very marked reduction in the prevalence of raised blood pressure. But this is not the case for all parts of the world, and if you just focus in on this little graph here, you can see that sub-Saharan Africa has not had the same trends as in places like the Asia Pacific region, for example, or even Europe, parts of Europe, and high-income Western countries. So sub-Saharan Africa, raised blood pressure has continued to increase over the last 40 or so years. And now Africa is considered to be the place with the highest blood pressure in the world. So blood pressure is a huge public health issue in most countries, if not all countries, in sub-Saharan Africa. So that's just placing a little bit of context why it's important to think about strategies to reduce blood pressure. This is data from the global, I'm just going to move my bar over here so I can see what I'm talking about. This is data from the Global Burden of Disease study published in The Lancet a number of years ago. And what this study has done, it's had a look at different contributions to deaths. And here we have mortality rate attributable to different parts of the diet. And here we have number of deaths. And what is really striking here is that you can see that for cardiovascular disease, which is this dark red, really diets high in sodium are the major contributor in terms of all dietary aspects. On this side of the graph, it's a bit difficult to see, but this is just looking at high, middle income and high income and middle income. And across all regions of the world, the same trend is seen. So it's really important to think about how diets that are high in sodium can be altered. Sorry, I'm just trying to move on. And if we think about ballooning costs of health impacts about different food systems, this kind of funny little round diagram here is showing losses in life due to non-communicable diseases. And it's probably difficult to see, but this is for low and middle income countries, and unhealthy dietary patterns are accounting for by far the majority of costs of health impacts in terms of unhealthy diets. So I'm guessing that most of you are pretty much aware of this figure that's come from the World Health Organization. And these were voluntary global NCD targets that were set for 2025, which is actually next year. So we're almost there. And at the time, the target was to try and reduce premature mortality from non-communicable diseases by 25%. This is on a global basis. And some of these best buys are indicated by these little round or oval shapes here. And you can see salt reduction. The global target was to try and reduce population level salt reduction by 30% and to also reduce blood pressure, raise blood pressure by 25%. So I'm going to be talking about dietary patterns, as well as then going to individual nutrients a little bit later on. I've mentioned sodium, but I'm also going to be talking a little bit about potassium. So it's important to identify what do I mean by dietary patterns. So dietary patterns are really the quantities, proportions, variety, combinations of different foods and drinks and nutrients in diets. And there is a picture here of the Mediterranean diet, which is the most studied dietary pattern in the world. And you can see it includes a range of different foods that characterize that particular type of diet. The other dietary pattern I'm showing here is one that has been promoted as being the most sustainable way to eat. So this is called the Planetary Health Plate. And what is indicated here, this is also called the Eat Lancet diet. And this has created a lot of controversy because in order to eat a healthy and sustainable diet, it's suggested that animal proteins are really massively reduced compared to consumption at the moment, and that these are replaced by plant proteins, but also, of course, by the majority of fruits and vegetables. So this is just trying to set the scene for what I mean by dietary patterns. This is a forest plot. So this is work we did a couple of years ago when we wanted to have a look at different dietary patterns and find out which dietary patterns were associated with the greatest reductions in blood pressure. And I'm just showing you the forest plot for systolic blood pressure here. And this forest plot here, if these lines, so these are individual studies of the different types of diets, and I'll explain what these are in a moment, different dietary patterns. If these lines are on the left side of this line here, it means that they favor a lower blood pressure. And if the lines of the studies are on the right-hand side, then it favors that's associated with a higher blood pressure. So hopefully what you can see quite easily is that there have been quite a lot of studies on the DASH diet. And again, I'll explain it in a moment. And once you combine all, so these are randomized clinical trials, so the highest quality evidence. Once you combine all of these studies together, you can get a composite measure. And this little diamond is showing you for each of these dietary patterns, what is the composite measure? And there's a weighting dependent on how big the study was. So it's a good way of having a look at all of the literature combined. So you can see that the DASH diet definitely favors lower blood pressure to the tune of about 5 millimeters mercury. Some studies have found greater reductions and some slightly less. The Mediterranean diet, there are less studies available, but again, this favors lower blood pressure. And then these kind of lesser known diets, the Nordic diet, again, is significant because it's the 95% confidence intervals of this triangle are on the left-hand side. And then the Tibetan diet, there's really only one study, which is not conclusive at all. So we've got a picture of, you know, under the best circumstances, if people follow these kinds of diets, we can expect their systolic blood pressure to drop around about 5 millimeters mercury, which would be comparative to drug treatment. The similar trend was found for diastolic blood pressure, but it was the effect was slightly less. So what do I mean by these different dietary patterns? Well, I've summarized these according to types of foods that are included in these dietary patterns. So the DASH diet was a huge randomized controlled trial where people were given this particular diet, which was very, very high in fruits. You can see 750 grams a day, vegetables, whole grains, some low-fat dairy products, some fish, a small amount of red meat, and daily consumption of nuts and legumes, with little in the way of discretionary foods such as snacks and sweets. The Nordic diet is quite similar, except it has a lot more berries, which have high polyphenolic compounds in them, which are also antioxidants. The Mediterranean diet, again, follows a similar kind of pattern, except higher in whole grains. And of course, the Mediterranean diet also includes a little bit of red wine as well. And one of the main components of the Mediterranean diet is olive oil as the preferred source of cooking oil. And then, of course, when we think about the Western diet, which is essentially the control diet of what most people in most countries now eat, you can see that, these are the control diets against which these diets are compared. So that gives you a little bit of a clue about what are the healthiest diets for blood pressure. This is a systematic or a review of systematic reviews. So it's kind of an umbrella review which came out just this week. And this is actually looking at cardiovascular effects. So which dietary strategies have the best cardiovascular effects? And this group looked at 6 components, 1, 2, 3, 4, 5, 6. Energy deficits. So we know that increased body weight is probably the highest risk factor for increased blood pressure. They looked at the Mediterranean diet. So these are all studies that have been published in systematic reviews. They looked at studies where sodium reduction has occurred, but also studies where sodium in table salt has been replaced with salt substitutes that are higher in potassium. And I'll talk a little bit more about that later. And then, of course, the DASH diet and also alcohol reduction and fish oil consumption or fish consumption. This is a bit of a busy slide, but here they're looking at outcomes in terms of blood pressure, systolic blood pressure, cardiovascular disease mortality, all-cause mortality, and then endpoints, so cardiovascular disease events. And I just want us to focus here on the blood pressure component. The colors are the quality of the evidence. that depends on how well designed these studies are. And again, it's a similar kind of thing for the forest plot. You can see just by looking, cardiovascular disease events were reduced with diets that looked at energy deficit, Mediterranean diet. Sodium reduction is interesting because it's kind of straddling non-significance, but for that's for cardiovascular disease events in people with high blood pressure to start. But when you have a look at systolic blood pressure as an indicator, not cardiovascular disease as an endpoint, you can see that that is a significant difference of 4.1 millimeters mercury. Not so much for normotensive, although there is a trend for that to be almost significant. So I'm just going to skip this, but I just wanted to set the scene for dietary patterns as a whole. So in the best circumstances, we know that for reduced blood pressure, if people are overweight, it's good to lose weight through an energy deficient diet. The Mediterranean diet is a very good kind of diet, and sodium reduction, especially in people with high blood pressure. But the problem is that people don't eat those kinds of diets. This is data that has been taken again from the Global Burden of Disease study that was published in The Lancet. And this is looking at, it was in 2017, all of the dietary intake from different countries around the world were pooled, and estimates were provided of what average intakes were and how these compare with what is considered to be the optimal intake for health. And what you can see is for fruits, so this gray at the top is the average for all global countries combined. And then you can look at each of the different regions. And if of interest to you will be sub-Saharan Africa, and that's divided according to Central, Eastern, Southern, and Western. And there are very few places in the world. In fact, there are no places in the world where fruit intake meets the optimal intake. The average is around about 100 grams per day. And you can remember some of those diets were even up to 750 grams of fruits per day, like the DASH diet. When you have a look at vegetables, some parts of the world, such as Central Asia, are meeting the optimal, but again, not many parts of the world, and especially not in the African region. Africa does pretty well in terms of legumes, especially in Eastern Africa and Western Africa. That's, beans, peas, lentils, that kind of thing. When we look at whole grains, again, nowhere in the world are we meeting what is considered to be the recommended optimal intake. And nuts and seeds as well fall far below what is recommended. So people are not consuming these diets, which we know are good for blood pressure and good for overall health. Going the wrong way, sorry. So that's dietary patterns. Now I'm going to focus for some of the talk on salt reduction. So I'm pretty sure you know that a high salt intake is associated with high blood pressure. And this is a summary of salt reduction strategies that have been or are conducted around the world. And in each case, there are two dots. The first one is in 2014, there was a summary analysis done around the world. And then this was repeated by the same group in 2019. So what you can see is that in 2014, about 75 countries had a salt reduction strategy. This increased to 96 in 2019. Some of these are legislative approaches, either a single legislation such as, maximum salt allowed in processed foods, for example, and some have multi-legislative approaches, but these are quite few. What's important to have a look at is that when we look at WHO region, Africa, only one country has a salt reduction strategy, and that is South Africa, and that's the country where I've been doing a lot of research, and that's where I'll talk to you about how that strategy came about. When we look at the type of strategy for salt reduction, there are various things you can do. You can have interventions in settings such as hospitals or schools or universities or wherever. Food reformulation, that means reducing the salt added to processed foods. Consumer education is, health promotion, asking people to eat less salt, and those seem to reduce over time, actually. And then front of pack labeling is informing consumers how much salt is in foods on the front of the pack, using either logos or other types of labeling. And then salt taxation, so adding a tax to foods that are more salty. That's not a very popular strategy that's been implemented. So that's kind of the first point, that in most countries in Africa, apart from South Africa, there are no salt reduction strategies in place. Okay, so let me talk you through an example of how things came to be in South Africa. So this is a bit of a roadmap, and you can see way back in the early 2000s, this is when I was starting my PhD, we wanted to find out what would be the best way to reduce population level salt intake in order to try and reduce population level blood pressure. And the first thing we had to do was actually identify what are the sources of salt in the diet, because there wasn't really any good information. And the only way you can do that is really to do repeated 24-hour urine collections and work out how much sodium is in the urine. And then that's a proxy for salt intake. So we conducted some of those studies, and we identified that bread, margarine, aromat is a monosodium glutamate flavor enhancer. I'm sure you have something similar in your own countries. And stock cubes. Those 4 components were making up about 40% of the salt that was provided from foods other than salt at the table. So in 2005, we wanted to find out whether, if we changed or reformulated some of those foods, what would that do to blood pressure? So I'm going to talk about that randomized trial now. So what we did was look at an 8-week food-based intervention, and we wanted to focus on people that were already at high risk of non-communicable disease outcomes. So we looked at people that already had mild to moderate hypertension. And what we did was we randomized them either to a control diet or to a reduced salt diet. And then over 8 weeks, we looked to see whether blood pressure changed and looked at various other components. We wanted to make this as pragmatic as possible. So we wanted to keep it as a real life type of intervention. So we didn't want people necessarily to change the way that they ate. We just wanted to give them foods that had been altered in some way to have less salt in them. So we worked with the food industry, and you can see that there's bread here, there's brick margarine. These are the most commonly consumed types of foods that we'd found out from our previous studies. Stock cubes, soup packets, because that's used as flavoring, and then salt and the aromat. And you can see the intervention diet that we gave was very, very similar. So you couldn't tell the difference between the breads, but these had been formulated to have about 30% less sodium. We used a salt replacement. You can see here's the salt shaker. That's normal salt, and that's the salt replacement. So everything looks identical, except we had reformulated these products. We gave sufficient for the whole household. So we delivered these foods to people's households because people share food. And we asked them just to consume how they normally would consume these foods. The only difference that is a different type of food altogether is that mass was given to try and increase calcium intake. That's a fermented milk product. And in order to keep fluid volume the same, people were given unsweetened cool drink in the control bag. So I've told you who we included: people with drug-treated mild to moderate hypertension, because that's the normal standard care for people with this level of hypertension. And we had a lot of exclusion criteria. Just to make sure that things were randomized, you can see we had a dedicated food packer. So the food would come to the Medical Research Council. We would have little tags on the bread, for example, so the food packer would know which is the low salt and which is the normal salt. And then the bags would be packed with tags, and then the driver would not know which group the participant was in, and he would drop these bags off at people's houses. So what did we find? Over 8 weeks, we found that the control group kind of remained the same. This is just systolic blood pressure, and here we've got diastolic blood pressure, whereas the intervention group dropped both systolic and diastolic blood pressure by over 6 millimeters mercury for systolic, and about 0.6 millimeters mercury, which was not significant for the diastolic blood pressure. So we were pretty impressed by this. This was, this is just by food reformulation, nothing else. We didn't intervene in any other way. We asked people what they liked and didn't like. They did not like the salt replacement. You can see that the people in the low salt group said they disliked it compared to usual salt. The people in the control group didn't know that they were getting usual salts, and they said, oh yeah, 90% said they preferred it. The bread was well accepted. The margarine was not well accepted. The low salt group did not like the low salt margarine. And the aromat, people didn't detect any difference. So what we were able to show was by food reformulation, first of all, we could actually achieve these reductions. So for example, in bread, it was a 32% reduction. There was no problem with taste or breadcrumb or anything like that. And we then went back to the South African government and said, look, we've got this data. We know what people are consuming. We know how to reduce population level salt intake. If you just focus on these 4 foods and mandate that food producers have to abide by those maximum levels in those foods, you can get these great reductions in blood pressure, even in people that already have hypertension, that are already on drug treatment. And just as luck would have it, so that was in 2005, we did our study. In 2011, the then Minister of Health heard about this data, and almost overnight at an NCD summit, he committed to regulating the food industry. It took a number of years then to get this legislation drafted, but then finally in 2013, the legislation came out and said, right, by 2016, we're having the first phase of sodium reduction in not just 4 processed foods, but a whole range, 13 different processed foods. And then food industry had another 3 years to reduce it further to more restrictive amounts. So these are the foods that the Minister of Health said had to be mandated in terms of the maximum amounts of salt that could be added to these foods. And it was predicted that by doing this, there would be an overall reduction of almost 1 gram of salt per day, 0.85 grams of salt per day. And then there was some modeling done to say how much that might reduce annual CVD deaths and how much reduction in healthcare costs that would lead to. But of course, the question is, would it work? Would the food industry comply? How is this all going to go? So we've done some analysis in terms of evaluating this salt reduction program. And this has been published in this report, in this journal here. And we looked at, we worked with the World Health Organization's SAGE study, which is a longitudinal study in 6 different low middle income countries, and South Africa and Ghana are the two African countries involved. And we collected information, urinary sodium excretion in wave 2 and wave 3 of this study. And I'll just show you quickly that salt reduction actually, or salt intake in these groups between wave 2 and wave 3 reduced by more than had been predicted. So it reduced by 1.1 grams of salt per day. That was between 2015, which was just before the first phase came in, and then 2018-19 when the second stricter phase was coming in. And you can see that this happened across males and females. So this is wave 2, this is wave 3. You can see that it was significant for both people with and without hypertension for males and females, and also for urban and rural males and females. So the only group that was kind of borderline were the 50+ male group. There was still a reduction, but it was just borderline significance. So we were pretty convinced that this strategy works. At the same time, there was another study that followed the same people from 2013 to 2016. And this study found very similar results to us. In their sample of Black adults, they found a 1.35 gram per day reduction in sodium. This is 24-hour urinary sodium excretion. And this was only significant really in the low socioeconomic status group. So this is baseline and this is follow-up, which is basically the target group that the legislation was really trying to get to. So 2 different studies, both showing very similar reductions in salt intake at the population level. I'm going to skip a little bit quickly now because I realize time is marching on. We've since gone back to South Africa to see, you know, there is this legislation in place, but there isn't really a stick for food industry that's not complying with it. So we went back to South Africa and we actually sampled 8 of the food categories. We collected food samples. We analyzed these in the laboratory to see whether the information on the packaging was actually the same salt intake that was in the actual food. I'll just skip over this because I don't think it's important. What this is showing you is when you have a look at the salt, the labeling on the back of the food package, you can see that some food categories were on target, but you can see that there's one particular category that was not, and that was the some of the meat products. But essentially most, in terms of the labeling, seem to be on target. When we actually compared the labeling panel with the analyzed values, again, these were very similar. What the product said on its label was actually what was in the product itself, and these were compliant with the legislation, except for this category of some processed meats. And this was a lot higher than what was indicated on the label. So there's one particular group, so the processed meats, which is still problematic in South Africa. So the work now has been done for other countries that want to follow suit. So the World Health Organization has come out with global sodium benchmarks for different food categories. So any country that wants to now follow suit can look at these food categories, and that's what they can benchmark their legislation against. All right, I'm going to skip because I know that you've got busy days and I'm speaking for a pretty long period of time. I just wanted to point out that in this same study where we evaluated the South African legislation, we've also collected 24-hour urinary sodium in Ghana. And here we can see that salt intake in Ghana, this was just in wave 3 in 2018, was pretty high. So the recommended maximum amount of salt intake is 5 grams of salt per day. In Ghana, the median salt intake was much higher than that at around, excuse me, around 8 grams per day. And this was highest in young people aged 18 to 49, almost 10 grams a day compared to older people. So I'm guessing that in most of your countries, you would be finding similar kinds of high salt intake. Why is this the case? This is because even in South Africa, where there is legislation, informal street vendors can add as much salt as they like. They're not covered in the legislation. And then, of course, the takeaway or quick service industry, such as KFC and other increasingly prevalent takeaways, are not covered in legislation in South Africa, and they tend to provide products that are very high in sodium or salt. We've also looked at the ratio between sodium and potassium, and this was, again, another systematic literature review, and these are just studies that looked at the ratio of urinary sodium to potassium, because we know potassium intake is protective against high blood pressure, and sodium increases high blood pressure. And when you have a look at this ratio, you can see that for studies where there was a lower compared to higher sodium to potassium ratio, overall, this lowered blood pressure, again, around about 4.38 millimeters mercury. That's the summary measure for systolic, and about 2.6 millimeters mercury for diastolic. So it's important not just to look at sodium intake, but to look at this ratio of sodium to potassium. I'm going to skip over this because we summarized a lot of studies from around the world. Again, only one from Africa, to try and work out what is the actual sodium to potassium ratio in the urine. And in China, it's really, really high, around about 7. In South Africa, it was around about 3. So again, I'm not sure in your respective countries where you would be sitting with sodium to potassium ratio. We need more studies to look and identify what is the optimal urinary sodium to potassium ratio in populations that have varying cuisines and that have very different dietary patterns. And that's particularly the case in African countries. I wanted to touch very quickly on this particular study because you may have heard about this. It's had a lot of coverage in the press and in scientific journals. So this was a study where regular salt was replaced with a higher potassium enriched salt substitute. This was conducted in China, and the unit of randomization was villages. So it was a very, very large study, including over 10,000 people in each of the arms. And they followed people for an average of about 4.5 years. And they were looking at endpoints such as stroke, major cardiovascular events, death from any cause, and of course, whether this potassium-enriched salt substitute would lead to hyperkalemia. And what they showed quite categorically was there was a significant reduction in stroke, a significant reduction in adverse cardiovascular events with this salt substitute, and of course, death also from any cause. And quite surprisingly, the prevalence of hyperkalemia was not different between the groups. The salt substitute that they used was one that was not too high in potassium. It was about 25% potassium chloride compared to 75% sodium chloride. That's just showing the same results in a graphical form. So this is looking at, can't see what that is. I've got this bar on the top of stroke, and then showing no difference between the two groups in terms of hyperkalemia. So the authors concluded that it would be safe to roll this out on a large scale. However, I would be cautioning against that at this point because there is a bit of evidence that potassium handling may differ between various populations, and people that have kidney disease or are at high risk of kidney disease, this may cause problems. So that was a huge study done in China, but this has not been replicated in other countries. But I did want to point it out. In terms of the prevalence of CKD, it's around about 6 to 8% in South Africa, and I'm not sure what the prevalence is in other African countries, and perhaps that's something we could discuss. So to conclude then, South Africa was the first country globally to mandate a whole range of processed foods to have maximum salt levels. We've shown that the industry, even though they were quite against these targets in the first place, and they did come out with all sorts of excuses that it couldn't be done, but we had shown in our studies early in the 2000s that it could be done, and they have been pretty compliant. We have seen a shift in salt intake at a population level. In terms of any implementation of such a policy, there needs to be monitoring and evaluation, and unfortunately that's not actually happening in South Africa. No government department has taken responsibility of that. NCD strategies need to include salt reduction as a best buy for prevention of high blood pressure. And I think I will end there because I'm hoping there may be some questions. So I'm hoping we might have time for some questions.
Yes, thank you, Professor Karen. That was quite an enlightening talk. I think it was interesting to see all the different types of diets from Mediterranean, Nordic diets, Tibetan diets, and on the effect on lowering blood pressure. I think it's also good to look at to see the studies that you have done, which have helped to inform policy and also helped in terms of legislation, in terms of salt reduction in our diets. I think that is quite good and quite encouraging, even to our nutritionists who I know are listening. And it encourages us to do more research on this, which can also help us to inform policy. So at this point, I would just like to open the floor to any questions, any additions or any comments. Feel free to post your questions on the chat box. And for the panelists, you can unmute and probably ask your questions live. I think Professor Bima has raised his hand. Professor Bima, you can unmute and ask.
Thank you, Yuri. And thank you very much, Dr. Charlton, for that very enlightening talk. It was really wonderful and good. I'm a pediatrician, so I'm going to ask a question with pediatric perspective. We did a study a little while ago, about say 6 years ago, and it was part of the World Kidney Day thing, where we went to schools, and these were not what do you call it, private schools in South Africa, but public schools mainly. And we did a study looking at the prevalence of hypertension in grade 12s, that is matriculants. So the average age was 17 point something. And to our surprise, I mean, I thought the statistician made a mistake when she did the calculation. Normally, you know, you get the prevalence coming out of about 2 to 3%. We had a 14%, 14.8% prevalence of hypertension in this baby. And largely, it was mainly because, and we didn't do this, I sent it to Professor Adams, but she hasn't published it yet. The food intake is exactly what you said. I mean, these kids are eating a lot of processed foods, which is very high in salt, and a lot of, what do you call it, sweets. And if you look at what the diet is for lunch, it is mainly burgers, KFC, and mainly sweets and cool drinks. So I agree with you that there has to be some regulation in place that has to monitor this, and especially for these fast foods, etc., to try and reduce the amount of salt intake, because that can, and the incidence of overweight, not necessarily obesity, but overweight, correlated very closely with the prevalence of primary hypertension. And so this is something very, very unusual that we found. And Professor Myers, who's late now from WITS, did a similar study in Charlton region, and he got similar prevalence. So, you know, it looks like the incidence of primary hypertension in children and adolescents, particularly 6 years above, is definitely on the rise, and largely due to the presence of obesity, overweight, and
yeah, and that is absolutely a massive problem, because we know that once adolescents become overweight, it's very difficult for them to change their weight status as they go into early adulthood, especially for the women, for the girls. So, you know, it's almost like a tsunami, if you like, a tidal wave is just waiting, you know, for the next generation to be coming through. And I think, you know, proximity of schools to fast food outlets, also, I know the practice of selling crisps and unhealthy snacks through the fence in South Africa to school kids is very highly prevalent. I'm not sure about other parts of Africa. So absolutely, it would be wonderful to do comparative studies of adolescents across different countries, and maybe that's something your group might want to be thinking about in terms of, you know, dietary intake and what can be done to reduce that in young people.
yeah,
Thank you for your comment.
It was very good, because if you look at these kids, and I took out a few pictures, they have the school, there's coats. On one pocket they have two packet of crisp and chocolates, in the other one is Coke. And it's really bad. You know? So,
it's difficult, yeah, it's very difficult. And I mean, the problem is that salt is palatable. So people like the taste of salt, and especially if you've been exposed to salt at a young age, you develop a greater liking for it. If your salt intake is lower as you get older, or when you're a toddler, then you're being exposed to solid foods, then you don't have such a high threshold for salt. So unfortunately, if young children are given, lots of salty kind of processed foods, they develop that liking for salt, which is quite difficult to shift.
Yes, yes. So in the chat box, there's a question from Dr. Arif, I believe he's from Tanzania. Question is, have you looked into the usage of more natural salt? Example is the Himalayan salt or rock salt against more industrialized processed salt.
It's a marketing thing. So it's pure marketing. Salt is salt, whether it's pink Himalayan salt, whether it's, sea salt, whether salt is salt, it's sodium chloride. So there is no difference. And in, I think, all African countries, salt is iodized. So I know that in Australia, Himalayan salt is more expensive and it doesn't contain iodine because we don't have an iodization program. So you'll also have to be looking at, whether salt is iodized, because that's where iodine comes from. So in short, salt is salt, whether it's Himalayan or wherever it's come from, it's still sodium chloride.
Thank you for that response. Another question from a participant by the name of Kelly, asking what would be your advice for dietitians about foods to target to get them more gains, like more fruits and vegetables or less salt or both?
Oh, that's a good question. And in fact, that's something that the DASH diet group, they did their DASH diet, and then people said, oh, maybe it's just the sodium. So then they did a DASH sodium study where they kept sodium or salt the same, and they gave it, so they had low, medium, and high salt, and then they had, in those various groups, they had the DASH diet or not. So if people follow a DASH diet, lots of fruit, lots of veggies, that kind of thing, and they still have a relatively high sodium intake, they're going to have similar blood pressure reductions to somebody that just cut sodium. So you can kind of do one or the other. Obviously, if you do the two together, it's best. But again, I think more needs to be done in terms of that urinary sodium to potassium ratio. If you can increase the potassium intake. So in all of our studies, we find potassium intake is particularly low, like around about 30 millimoles per day compared to, should be around about 90. And that's mostly from fruits and from vegetables and some animal products. So if that could be the case, then you're probably going to see that shift as well. So it's kind of one or the other, preferably both. I don't know if that answers the question.
Thank you for that. I think for the next question, I believe you have touched a bit on this. Participant from Tanzania asking that in Tanzania, there has been different campaigns on iodine deficiency, and people are encouraged to use iodated or iodized salts. So regarding the salt substitute, do you suggest it to be iodized? And what's your opinion on this?
Yeah, that's a really, really good question. Iodine is my most favorite micronutrient. And we've been looking at the effects of reducing sodium in the food supply and what that does to iodine intake. So looking at urinary iodine concentrations. A lot of food processors in South Africa thought that they were not using iodized salt because it's not mandatory to use iodized salt in food processing. It is mandatory to sell table salt that is iodized. But when we actually looked at foods and looked at the concentration in foods, most of the processors were actually using iodized salt without even knowing it. So of course, if you're reducing salt in the food supply, you're probably going to be reducing iodine. I don't see it as a problem, and the WHO now has recommendations that any salt reduction strategies need to also be monitoring iodine status, and it's relatively easy to tweak the amount of iodine in table salt, particularly, and if people are having 5 grams, or let's just say they're having 2 grams of table salt a day, because the rest would come from processed foods, that amount of iodine added in terms of parts per million to the salt can be changed not in a not too difficult way. So it's a really good question that you do. What I would not be doing is pushing salt because of the iodine. I think there's other ways of dealing with the iodine. And in fact, a lot of countries in Africa now probably have over-iodized populations. People may be consuming a bit too much iodine, to be honest.
Thank you. I think the next question from a participant by the name Chetna is more of a case scenario, asking about a patient who has been on antihypertensive medication for a long time. The patient is vegetarian and on low-fat diet. So asking, does this patient still needs to control the salt intake?
Blood pressure is still high. I think all hypertensives, one of, the first line of lifestyle modification is reducing salt. So I would definitely say yes to that patient.
Thank you for this wonderful session, covering a lot of ground, which were actually great insights. A lot of very important aspects covered. How can more countries be coaxed to lay down legislation and implement the same? But I think that will have a lot of impact over time. Educating both the government and the population at large, and definitely will have a big impact because the whole system is involved.
Yes, and it's not an easy task, but
yes,
I think data is always the thing that is important. I mean, I would imagine that all countries represented here today would have some NCD strategy, I'm guessing. And that's kind of where you want to be looking in that strategy to say, right, well, this salt reduction is a best buy. Here's an example of how it's happened in other countries, such as South Africa. This is what they did. Why don't we just follow suit? You don't have to reinvent the wheel because, we know that all countries really have a westernized kind of diet, especially with the flooding of the market of unhealthy foods. So it's really to try and make a noise about it and show, is blood pressure increasing? If it is, then, what about the cost? Get some economists on board, health economists, to do some modeling, like they did in South Africa with our data. If we reduce by this is how much we can save in terms of cardiovascular events, hospitalization, and so on, because politicians want to know about reduction in cost of health services, essentially. But again, you just have to be a little bit fortuitous as well and have a minister that has this in their sights. And hopefully, I mean, it's a pretty sad situation that only one country on the whole continent of Africa is kind of looking at salt in a serious way, when we know that the salt intake of populations is almost double what the WHO are recommending. I mean, I showed you that data in Ghana. It's like 8-9 grams of salt per day. That's too much. It needs to be brought down to about 5 grams maximum. So good luck to all of you, but you're a group, like together you have a voice.
Thank you so much. Thank you.
Thank you, Professor Karen, and thank you for the challenge. I think Dr. Lloyd is up to the task, together with a big team of nutritionists here.
Excellent.
So
I
we can
look
try
forward
and
to
push
hearing.
policy.
I look forward to hearing great things.
Yes, definitely.
Thank you very much for having me, and happy World Kidney Day, everybody.
Thank you so much. It's a wonderful day. And on a right day too, on a very right day.
Yes,
Thank you so much.
That's right. Thank you. Bye-bye.
Thanks.
Thank you. Bye-bye.